Hello, my name is Jeremy Cody. I'm a student at West Texas A&M University, the nurse practitioner program. Today I had a gentleman come in for a general physical examination. Um, Previous to coming in, he filled out a general survey. Past medical, we went over his past medical history, surgical history, sexual history. We went over his allergies. He's got no known drug allergies, no allergies to food or latex. We took his vital signs, all within normal limits. We took his height and his weight, and we also did the Snellen E chart, vision acuity, and he is 20/20 with corrective lenses. He is alert and oriented, well groomed as you can see. He uh, is confident with his eye contact and maintaining while we're doing the interview. While we were doing the interview earlier, and his speech is clear and fluent. Uh, Now we're just going to start the assessment. I'm just going to do some neurological uh, assessments, ask you some questions. What year did you get your first car?
1977.
Excellent. Um, if you're going to go to the beach, what are three things that you would take with
Umbrella, suntan lotion, and beach towel.
you? Excellent. If you, if at your work, you were getting paid bi weekly for 6 months, at the end of that 6 months, how many checks would you have accumulated?
12.
Excellent. So, uh, by his immediate response to remote and recent memory, his abstract thinking, reasoning, judgment, and calculations are all intact. Now I'm just going to do a couple tests. Uh, oh, here it is. Okay. So I'm just going to have you, this is called the pinpoint prick test, and I'm just going to have you close your eyes and tell me this is a dull, this is sharp sensation, this is the dull.
Okay.
And if you can just differentiate for me.
Okay. Sharp. Dull. Sharp. Dull. Sharp. Sharp. Dull. Sharp.
Excellent. Okay. If you just keep your eyes closed again, I'm going to have you put out your hands, and I'm going to give you two objects, and I'm going to have you differentiate what they are. What's this sensation?
This is a key, and this is a quarter, or it feels like a coin.
Excellent. Um, Sturginosis is intact. Now I'm going to have you keep your eyes closed, and I'm going to write a number in your hand, and I'm going to have you tell me what that number is. Okay?
Okay. 7. 9.
Excellent. Graphicesi is intact. Now I'm going to do a thing called proprioception. Okay, so it's a position test. I'm going to have you keep your eyes closed.
Okay.
And then what I'm going to do is I'm just going to have you tell me. I'm going to move your fingers around. I'm going to have you tell me which direction they are. Okay.
Okay.
Okay. So if you just close your eyes, can you tell me
Up, down, right, left,
excellent. Now I'm just going to do your toe.
up, down, right, left,
Let's do this one over here.
up, right, left, down.
Excellent. Proprioception intact. Now we're going to do another one. I'm going to have you close your eyes and take your heel on this leg and slide it down your shin. And we'll do that on both legs bilaterally. Okay? Excellent. Heel to shin is intact. So now what we're going to do is I'm just going to do a general inspection. And what I'm going to do is just look at his arms, his legs, feel his skin. His skin is dry and intact, warm. What we're going to do once we take off his shirt too, when we do inspections, just look for generalized bruising, his hair distribution. I don't see any discoloration of the legs showing vascular problems. I don't see any varicose veins, and I don't see any masses or moles that we should be looking at. Okay? The head looks good, and we'll do an inspection here in a second of your head.
Okay.
The skin looks good, generalized assessment. Now we're going to do the head. I'm just going to take a quick look all the way around. I don't see any cuts, lesions, scars, anything like that. The eyes, nose, and mouth are midline. The ears are symmetrical. The eyebrows are symmetrical and evenly dispersed. I'm just going to palpate your head now. I don't feel any lumps or bumps. I don't see any lesions or pest infestations. What I'm going to do now is I'm going to feel your pulses, your temporal pulses, and I don't feel any thrills. They're 2+ in strength. Now what I'm going to do is I'm going to test your called your temporal mandibular joint, and we're just going to test this joint right here. I should be able to fit 2 to 3 fingers back behind your ear. I'm going to have you open your mouth, move it from side to side. Excellent. No clicking noted. Also, what I'm going to do is I'm going to feel your frontal sinuses and your maxillary sinuses. Do you feel any tenderness when I press on those? No. Excellent. So, frontal sinuses, no tenderness, TMJ is intact, temporal arteries are 2+. Now what we're going to do is we're going to do an assessment on your eyes. So if you can take your glasses off. What we're going to do is we're going to do pupil assessment. I'm going to have you close your eyes and then open them. Close your eyes, open them. Close your eyes, open them. Close your eyes, open them. Excellent. Direct and consensual pupil response is intact. Now what I'm going to do is I'm going to have you look at this pen and then look at the wall. Excellent. Accommodations intact. Now what I'm going to do is we did pupil response. What I'm going to do is I'm going to have my pen right here, and I'm going to have you follow it to your nose, okay? Convergence is intact. Now what I'm going to do is we're going to test what's called the EOM, your extra ocular motors, your movement.
Okay.
And what we're going to do is we're going to look for the ocular and the trochlear and the abducens. That's cranial nerves 3, 4, and 6. The ocular is the movement when you look up. Trochlear is when you look down and inward, and the abducens is when you look lateral. Okay? So what I'm going to do is we're going to do that by the cardinal field test. I'm going to have you follow my pen, but don't move your head when you do that, just with your eyes. Excellent. Cranial nerve 3, 4, and 6 are intact. Now what I'm going to do is do what they call a fundoscopic exam, and I'm going to look for your red reflex, and then I'm going to look inside your eye and see if if we have any problems with vascularization or your optic disc. Okay, so I'm going to do right eye with right eye. I'm going to place my hand over your head just so I can get a good visualization. Okay, red reflex seen. Go in. Fundus is orange. Vascularization, no hemorrhage noted. Okay, I'm going to come over to this side. Left eye, left eye. I'm going to place my hand on your forehead again. Looking for the red reflex. Fundus is orange in color. Vascularization, no hemorrhage noted. Excellent. What I also am going to do is I'm going to look for, if you just look forward, I'm going to look at your lenses, and I don't see any foreign bodies or anything going on with that. Okay? Excellent. So we did pupil constriction, we did the pupils, we did the extra oculomotor, we did the fundoscopic exam. Now what I'm going to do is I'm going to look at your ears. I'm going to inspect first. I don't see any drainage, redness, any excessive hair growth or anything like that. what I'm going to do is I'm going to palpate now. I'm going to feel your auricle, palpate your helix, your tragus, and your earlobes. No masses or nodules felt. Okay, noted. What I'm going to do is I'm going to look inside your ear now. And what I'm going to do is I'm going to look at the external ear. For adults, pull back and up. For children, you pull down, back and down. I'm going to look inside your ear. I don't see any exudates or swelling, or anything in the external ear. There's a little bit of light cerumen, earwax. I see your tympanic membrane. It is flat, no bulging noted. I don't see the bony prominences behind it, but it looks pearly gray. It looks good. Now we're going to look over on this side. The external ear, I don't see any swelling, no redness. Light cerumen, again on this side. Tympanic membrane is flat, no bulging noted. And pearly color gray. Looks good. Excellent. So what we're going to do is we're going to do some tests of cranial nerves with the ears. What I'm going to do is I'm going to test. It's called the whisper test. Okay. I'm going to be behind you, and then I'm just going to have you tell me what number I call out. Okay.
Okay. 74.
Excellent.
52.
Excellent. So we just showed that cranial nerve 8, the vestibular, is intact. So we did your eyes, we did your ears, and now we're going to do your nose. First, I'm going to have you test patency. So if you just close one nostril, breathe in, and then do it to the other side. Excellent. So patency is good. Bilaterally, no nasal flaring on inspiration. Now what I'm going to do is I'm going to pull up your nose and I'm going to look inside. And what I'm looking for are lesions or polyps. The mucosal is pink. No discharge noted, and no septal deviation on either side. Noted. Excellent. So what we're going to do now is we're going to test your olfactory nerve, which is your smell. So what I'm going to do is I'm going to have you close your eyes. I'm going to have you close one nostril, and then tell me what you smell on this one, okay?
Alcohol.
No. Sorry. Here, what we'll do is I think the coffee ran out on that. So what we'll do is let me see what we can do. We'll do just close one there. Close one side.
Oh, on my nose.
Yes. If you tell me what you smell.
That is alcohol.
Okay. Sorry, I didn't mean to get so close. And then can you do the other side?
That is alcohol.
Excellent. Okay. So we showed that the cranial nerve 1 is intact with the olfactory, with the smell test. We did the Snellen E-chart for cranial 2, the optic. We did extraocular motor, or extraocular movement showing 3, 4, and 6 are intact. And now, before we move down to the mouth, I'm gonna test the trigeminal, which is cranial nerve 5, and facial, which is cranial nerve 7. What we're gonna do for the trigeminal, I'm gonna have you just lie down in your jaw, so we show the motor aspect of trigeminal cranial nerve 5 is intact. What I'm gonna do is I'm gonna have you close your eyes, and just like we did earlier with the pin prick, I'm gonna have you tell me what's the difference in sensation. Is that sharp or dull?
Dull. Dull. Sharp.
Excellent. So we showed that sensory and motor for the trigeminal nerve is intact. Now what I'm going to do is I'm going to test your facial, and we're going to do motor. I'm going to have you. Can you smile for me? Can you frown? Can you show me your upper teeth? Show me your bottom teeth. Excellent. Can you squint your eyes? Can you close your eyes real tight? Can you raise your eyebrows? Can you puff your cheeks? Excellent. So the motor aspect of that is good. Now we're going to do test the sensory. I'm going to have you close your eyes, and I'm going to have you differentiate a test. Okay, so I'm going to have you stick out your tongue and then just tell me what you taste. Okay, differentiate. What do you taste?
Do it again. Bitterness.
Okay,
Salt.
excellent. I'll do this one.
Sweet.
Excellent.
I don't know what it is.
It was sugar. So
Sugar.
yeah, so we showed cranial nerve 5 is intact and cranial nerve 7. So we did the eyes, the ears, the nose. Now we're going to do the mouth. Okay, so I'm going to look inside your mouth if you just open it for me. I'm going to look at the soft and hard palate. I'm going to look at the dentation. I'm going to look at the top of the tongue, the no whiteness. Taste buds are intact. I'm looking in the back of the throat, looking at the tonsil pillars. He's a grade 1. I'm going to have you say "ah" for me. Ah. Excellent. Now I'm going to stick this Q-tip back there, and we're going to test your gag reflex. Excellent. Gag reflex isn't intact. What I would do now is I'm going to have you stick out your tongue. Can you move it left and right? Okay, so we showed cranial nerve 9, the glossopharyngeal is intact by the gag reflex. We showed cranial nerve 10 with the rise of the uvula, and we showed the hypoglossal 12 with the protruding of the tongue and the movement. Okay, so now I don't have any gloves, but I would palpate inside your mouth, feeling for masses, indentation. What I'm also going to do is, can you lift the bottom of your tongue? I'm going to look for the vascularization of the tongue, and it looks good. I'm looking at the frenulum, it is intact, and it doesn't look like the sublingual ducts are clogged. So, alright, now we're done with the mouth. So we did the eyes, the ears, the nose, the mouth. Now we're going to do the neck. I'm just going to have you look up. So we're seeing that the trachea is midline. What I'm going to do is I'm going to feel for your lymph nodes, okay? And we're just going to test there. With the preocular, postocular, tonsillar, submandibular, segmental, precervical, post-cervical, the deep cervicals. Sometimes the deep cervicals are hard to feel, so what I'm going to have you do is lean to the left, and sometimes you have to dig deep behind that sternocleidomastoid muscle, and we'll have the back. Now we're going to do supraclavicular, and last the occipital. What we're looking for is pea-sized lymph nodes, mobile and non-tender. If we had fixed, tender, or non-mobile, then we would further evaluate. What I'm going to do is, just while we're here, I'm going to test if you shrug your shoulders. So we just showed that cranial nerve 11 is intact by the shrug test. What I'm going to do is I'm going to come behind you posteriorly, and I'm going to check your, I'm going to palpate for your thyroid. What I'm going to do is I'm going to find the carcoid cartilage. I'm going to have you swallow, and when you swallow, it raises that isthmus. I don't feel anything, any nodules or anything like that. What sometimes you can do is have the patient lean their head, deviate the trachea, feel around, come over this way. Excellent. No palpation of the thyroid was noted. So we did the eyes, the nose, ears, mouth, and throat. Now what we're going to do is we're going to move to the chest, okay? So you don't have a gown on like you would be in the hospital, but I'm going to have you take your shirt off. So what I'm going to do first is just inspect your chest. I'm looking for um, any masses, any ulcerations, lacerations. Uh, we're going to talk about the breast um, assessment later, but I'm looking for symmetry, and I'm looking for uh, even rise in chest fall with respirations. You're showing no acute distress, no use of intercostal muscles or accessory muscles. So now I'm going to test your AP diameter. I'm going to have you hold your arms by your side, and you want this to be 2 to 1. So there's 2 to the 1. If you had more distance, it could indicate barrel chest, which most patients with COPD have. Second, what I'm going to do is I'm going to palpate your chest, and what I'm feeling for any subcutaneous air pockets. I'm feeling for pulsation, uh, uh, lifts, thrills, or heaves. And what I'm going to do now is I'm going to just do the cardiac portion. I'm going to feel the right second intercostal space, the aortic, and the left second intercostal space, the pulmonic. 2, 3, and 4 of the left intercostal spaces is called the Erb's point. The fifth intercostal space left is the tricuspid, and the fifth intercostal space midclavicular line is the mitral. That's the apex of the heart. And I'm just feeling for a point of maximum impulse. If there is lateralization to the impulse, it could indicate that you have a large heart, and we would further evaluate that. What I'm going to do now is I did inspection, we palpated, and now I'm going to percuss your lungs. Okay. So what I'm going to do is we're going to look for resonance. If we feel a dullness, it could indicate that we're on the rib bone, but it could also indicate that you have fluid in your lung, and we further evaluate that too. Okay. Excellent. So no dullness noted, and we had percussion, and we saw some resonance in the chest. We don't resonate, we don't percuss the heart anymore because the male muscularization and the woman's breast is just not very accurate. So now what I'm going to do is I'm going to auscultate. This might be a little cold, but when you feel the diaphragm of the stethoscope hit your chest, can you just breathe in for me? Excellent. Excellent. While we're here, I'm going to fill your axillary lymph nodes and just make sure those are okay too. Excellent. Axillary lymph nodes are okay too, also. Now I'm going to wash my hands. So we did inspection of the chest, we did palpation, percussion, and auscultation. Now I'm going to listen to your lungs. Okay. Not your lungs, your heart. And what I'm listening for is a good S1, S2, which is the systolic and the diastolic. And the S1, the systolic, is usually heard better at the apex of the heart with the left ventricle, and then the diastolic, the S2, is usually heard better up here. What I'm also going to do now is I'm going to just listen for murmurs. What I'm going to have you do is just lean forward a little bit, and just it will help us get a better uh, closer to the heart. Excellent. So with auscultation of the lungs, we didn't hear any adventitious sounds of wheezing, rhonchi, crackles, or anything like that. We heard resonance, clear auscultation on the anterior aspect. And then with the heart, no murmurs, no gallops, no clicks were noted, no rubs, and we heard S1 and S2 clearly. Now what we're going to do is we're going to have you lay down. And what we're going to look now for is it's called JVD, jugular vein distension. What it is the superior vena cava comes down. It's the biggest vein you have. Comes down to the heart. If it has increased pressure, that's what we're going to be looking for. And what it could indicate if we do, the ranges are three to four is or below is okay. But if it's anything higher, it could indicate congestive heart failure. So we're just going to take a look at that. If you look to your left, so patients who don't have it, we're going to come to the sternal notch. And what we're going to do is we're going to measure from the meniscus, the highest point of what we see. And yours is at 2.5, so you are looking good. That's good. What I'm going to do while you're laying down is I'm going to feel your carotid pulse. And it is +2. What I'm going to do now is I'm just going to listen to it, and we're going to be listening for a thrill or swishing or wishing, or it's called a brooding. We're just going to listen with our bell. Or set the scale. And no bruiser. So now while you're laying down, I'm just going to do an inspection of your abdomen, okay? So what we'll do is I'm just going to do an inspection. We see there's no scars, no ulcerations, no bruising, no masses, nothing protruding. It is round, and which is expected. I don't see any peristalsis visually. I don't see any the aortic pulsation visually. What I'm going to do now is I'm just going to auscultate your abdomen, okay? I'm going to listen over the right lower quadrant, left upper quadrant, or the right upper quadrant, left upper quadrant, and the left lower quadrant. And we'll listen for splenic and liver rubs. You have hyperactive vowel sounds. Within 5 to 30 seconds is when you usually hear them. In order for me to say that they're absent, I would have to wait 5 minutes in order to say that. Listen. Did inspection. We did auscultation of the abdomen. Now I'm going to do percussion. Okay. So I'm just going to percuss over the quadrants. Okay, and we want to hear timpani. We don't hear any dullness, anything of saying like organ megaly, which is the organs being enlarged. Okay, and so now what we're going to do is we're just going to test your liver span. Okay, and we're just going to. Okay, and what I'm going to do. I'm just going to mark this. Then I'm going to come down from the. It's usually found in the left fifth visceral macroventricular line. What we're going to do is we're going to measure the distance here in centimeters. And you are at 5.5. 6 to 12 is normal for the liver span. What we're going to do is we're going to come over to this other side. I'm going to come down to the 12th rib, and I'm going to come up to about the 10th. And what I'm going to do is I'm going to percuss. I'm going to have you take a deep breath for me, and hold it. Okay. Okay, let it go. Excellent. So, what we're seeing is for the liver to rise with the respiration, and shows that we didn't hear any dullness. So no splenomegaly. What I'm going to do now is I'm just going to do a light palpation. Okay. So we're just going to look for grimace, any tenderness, any masses that can be felt in light palpation. But if you do feel any tenderness, let me know. If you do have tenderness, we would look at that last while we're palpating, okay? Okay, excellent. So now I did the light palpation. Now I'm going to go a little bit deeper and do a little bit deeper palpation and see if we can feel the lungs or anything, or not the lungs, the organs. I'm going to have you take a deep breath, see if I can feel that. The report, okay. You can let it out. You can let your breath out.
Yeah.
Okay. Excellent. So some things that we can do on palpation. It's called McBurney's point. If to the left of the umbilicus, if there's some tenderness, it could indicate appendicitis. If we were feeling in the right upper quadrant and we had you take a deep breath and we palpated deep down in there and you had extreme tenderness, that could indicate cholecystitis. Okay. So what if we palpated? I didn't palpate the spleen, didn't feel it. That's normal. But if we did, we would hear that in the left upper quadrant. And then what I would do is a deep palpation. We could feel your colon. Sometimes that is tenderness. That's just slight tenderness. That could be just bowel, and that could be normal. But if we press deep palpation, and it's called rebound tenderness, if you feel pain on this side, that could indicate appendicitis. So we did inspection, auscultation, percussion, and palpation of the abdomen. So now what I'm going to do is I'm just going to do peripheral vascularization and test your pulses, okay? So I'm going to start distally and move proximally. What I'm going to do now is I'm just going to look at your fingers, and we're going to test capillary refill, and that is under 3 seconds. I'm just going to test your radial pulse, and that's +2 strength. I'm going to test your brachioradialis, and that's +2. We did your carotid. So now what I'm going to do is I'm going to feel for your popliteal. You can relax. And that's +2. And then we're going to do your dorsalis patelis, and that's going to be on the anterior aspect of your foot, and the posterior tibialis, which is on located near the medial malleus. Okay, now we're going to come over bilaterally. On the fingers, as long as I don't notice any clubbing, recovery flow is below 3 seconds. Going to feel your radial. Feel your brachial radialis. +2. +2 strength is just good. I'm going to do your popliteal. You can relax. Excellent. Do your dorsal tibialis. Posterior tibialis. And that's located in the medial malleus. Bilaterally, all your pulses look good. Okay, so we did your peripheral vascularization. What I'm going to do now while you're laying down is I'm going to test some musculoskeletal. Okay, so what I'm going to do is I'm going to test your flexion. I'm going to have you bring your hip up. We're going to do your left leg. Excellent. And what we'll do is we'll test internal and external rotation. So if you just bend your leg here, and we'll just turn in, turn out. We'll test abduction, adduction. Okay. So now we're just going to come to the other side and do the same exact thing. Keep your leg bent. We'll do internal, external, internal. We'll do abduction, adduction, and then we'll do flexion. Okay? Excellent. So now we're going to come to the knee. We're going to do, you can bend it. We're going to do internal, external. And what I'm going to do is I'm going to have you raise the knee and then bring it back down. Now I'm going to have you do it against pressure. Bring it down. Excellent. Flexion and extension of the knee is good. Now we're going to do this side, same exact thing. Bring it down. Now go against resistance. Excellent. Now we'll do internal and external. Excellent. Now I'm going to come down to your feet, and I'm going to have you, like you're pressing on a pedal, do dorsal and plantar flexion. Now we'll have you bring it back up. Now we'll do it against resistance. All right, we'll supinate, pronate. Excellent. Now we're going to do, excellent. Pull up, push down, pull up, internal, external. Good. So your musculoskeletal, we did the flexion, we did the abduction, did the knees, ankles, and now we're going to come up. Excellent. So now while we're up, we're just going to do range of motion exercises with the upper body too. Okay. So I'm going to have you take your shoulders, abduct back, adduct in. Excellent. Can you extend back, and then can flex? Yes. Excellent. So that's all good. Now I'm going to do your elbows. I'm going to have you pull towards me, and then push, straighten your arms. Excellent. So now you're going to pull up like this. Excellent. And then extend your arms. Excellent. So now I'm going to do your grip strength. Okay. Now we're going to do wrist. We're going to have you flex in, flex out. Excellent. Now we're going to do against resistance. Okay. Excellent. Good job. Okay. So we did upper body range of motion to the shoulders, elbows, and the wrists. We did the grip strength. Now we're going to test the reflexes, okay? So what I'm going to do is I'm going to test your triceps, and I'm just going to have you relax. Excellent. Excellent. Okay, we're going to do your biceps. Excellent. Excellent. Now we're going to do your wrists. Okay. Excellent. Now we're going to do your knees. What we're going to do is we're going to have these dangle. Excellent. Good job. Good job. And then I'm going to come back over here and we're just going to do your Achilles. So you have +2 strength on all your reflexes, and you have good strength on all your range of motions of the musculoskeletal system. So now we did anterior We did the anterior chest. We did the heart. We did the abdomen. We did the arms. Pulse. We did peripheral vascularization. And now we are going to turn around and we're going to do the posterior aspect of your back. What we're looking for is, like in the front, even rise and chest of the back, no labor breathing, even, no cuts, no moles, no lacerations in the back, no discoloration, no bruising. What we're going to do is I'm going to have you breathe in and I'm going to test chest expansion. Okay. Now, exhale. All right. And inhale. Exhale. Chest expansion is good. What I'm going to do is it's called CVA tenderness. I'm going to hit your costovertebral. I'm going to test your kidneys, okay? Do you feel any tenderness? Excellent. So we did an inspection. We did palpation. What I'm going to do is I'm going to have you say, it's called tactile fermentis, and I'm going to have you test, I'm going to have you say 99, okay?
Okay. It's 99. 99. 99. 99. 99. 99. 99. 99.
Excellent. While I'm thinking about it, I'm going to come over to the front side and also test for tactile fermentis with the palm of my hand. Do the same thing.
99. 99. 99. 99. 99. 99. 99.
Excellent. So we heard you're going to hear vibration. What we're really looking for is it to be symmetrical on the lateralization, and yours was on both sides. Okay.
Okay.
So we did inspection. We did palpation. Now we're going to do percussion. Okay. And so I'm just going to. Okay, so now what we're going to test for is it's called diaphragmatic excursion. We're just going to see your diaphragm, how it expands and on inspiration and expiration. We're going to test between those and see where it's at. Okay.
Okay.
So I'm just going to come down real quick. Actually, let me grab my pen. I'm gonna have you. Okay. Just gonna do this bilaterally. I'm gonna have you take a deep breath. Excellent. Okay, so now we're gonna measure between these. 3 to 6. 3 to 6 is the normal. Yours is 5. 5 on bilaterally. 3 to 6 is a normal measurement for the diaphragmatic excursion. Athletes can have up to 7 or 8 because their lung expansion is a little bit more. While I'm thinking about it, we're gonna, for the ears, we're gonna also do a test called a Weber's test, and we're gonna test bone conduction. Okay, so I'm gonna hit my tuning fork and I'm gonna place it on the top of your head, and I want you to tell me if you feel vibrations in hearing on both sides. Okay. Let me try this. Feel it on both sides. Excellent. So the lateralization and bone conduction is good. Now that's called the Weber's test. Now what we're going to do is called the Rhine test. What I'm going to do is I'm going to stick this on your mastoid one, and I'm going to tap it. I'm going to have you tell me when you can't hear it any longer, and then we're going to come back to the front. Okay. So what we're testing is the air conduction and bone conduction. up here? Oh, okay. I'm gonna try it one more time. Okay. Okay. You still here? Excellent. Okay, so now we're gonna do the other side. Excellent. So, air conduction is greater than bone conduction, and that's what we were looking for. So we did the head, we did the anterior portion, we did your abdomen, we did the cardiac, we did your back, posterior, the lungs. I'm going to come back and listen to those, but we did your reflexes and your peripheral vascularization. I'm going to come back and listen, auscultate. What I'm going to do is I'm going to listen for, it's called bronchophony, and I'm going to have you say, and I'm going to have you say 99, 99, and when we get down here, we're going to test for egophony. And so we're going to just have you say E, okay?
Okay.
Okay.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay. And then I'm just going to listen to you. Excellent. So, we heard muffled sounds all the way throughout, and that's what we were looking for. If we didn't, if it was clear, it could mean consolidation in your lungs. So now we're going to do one more test. I'm going to have you stand up for me. I'm going to have you close your eyes, and we're going to test for ataxia. It's called the Romberg's test, and I'm just going to have you stand there, and we're testing for balance. Okay. Okay. Excellent. Now, what I'm going to do is I'm going to have you walk just normal, and I'm going to just watch your gait. If you could just walk. Excellent. Now I'm going to have you walk from heel to toe. Excellent. And now can you do on your tiptoes? Excellent. So neurologically, we're all intact there. What I'm going to do now is I'm going to have you sit back down, and we're not going to do a breast exam, a genitalia exam, or a rectal exam. I'm just going to walk you through it of what we would do if we were in a real clinic. For the breast exam, what I would do is I would have you hold your arms to the side, and I would just inspect. Again, I would be looking for symmetry, any masses, any lumps, any discoloration to the areolas or to the breast. For women and for men, sometimes symmetry isn't always the same. Sometimes people have different, but if it's acute and just happened, then we would need to further evaluate that. So I'm going to have you hold your arms above, and I'm also inspecting. I'm just looking for symmetry and looking for the same things. I'm going to have you hold your, excellent, and just looking for the same things. I'm going to have you lean forward. Excellent. So what I would do now is I would have you lay down, and this is self-breast examination that you can do on your own. So when you do it, you can even do it in the shower. You put your arm over here, and then you start with the tail of the breast. And some people do it differently. They do it like you're mowing a lawn, and they come down, and then they come up. And then a lot of people you take two or three fingers, and you can just come around like a cone, and just in circular motions, and you're just feeling for any masses, any breast tissue. So for men, most breast cancer starts behind the areola, behind the nipple. So if you feel breast tissue, that sometimes you have it, but if it's fixed or it's or new, you need to get it further evaluated. The nipples, if they're inverted, flat, or pointing in a different direction, or discolored. An orange discoloration is another indication of breast cancer. That's something that you would want to come back in. Okay. And then what we would do for the genitalia is I would have you stand up, which you don't have to do, but I would just inspect, and then I would be looking for masses, lesions, anything that's protruding, like hernias or anything in that area. And then I would palpate. I would look at the shaft, looking for lesions, any cuts, any bruising, discoloration, any masses. And then if you weren't circumcised, you'd pull the foreskin back, and you would look at the meatus, and you would make sure everything's good, no discoloration, any masses like that, and you would look at the urethra and squeeze. And if you had any discharge, I would take a specimen sent to the lab, just to make sure. And then after palpating the penis, I would palpate the scrotum. I come back posteriorly and feel the epididymis, and I would then follow through with the spermatic cord. We would feel your testes for any masses, any difference in size, any swelling. We'd be looking for that edema factor. And then I would take some of the scrotum skin, and I would come up into the inguinal ring, and I would be feeling for hernias bilaterally. And then I would feel in the femoral areas for any hernias. We'd be checking for hernias. When I do that, I would have you cough, and then or I'd ask you to bear down like you're having a bowel movement, and then that might push that out if you did have a hernia. Okay, protruding. Then for the rectal exam, I would have you lay down in kind of a fetal position. I would have you have your right leg. I would have you lay down on your left side, have your right leg up. What I would look for is the perianal area, and just above, looking for lacerations, cuts, masses, or anything like that. Discoloration, and then I would look at the sphincter, the anal sphincter, looking for hemorrhoids, anal fissures, or anything like that, anything that's abnormal. And then I would ask you to, I would say, so I'm going to have you squeeze the sphincter, and we look at the elasticity of it. And then I would get a glove and tell you, hey, I'm going to insert my finger in your rectum now. I would move in a clockwise and a counterclockwise motion against the walls of the inside the rectum, and feeling for masses, any indentation, anything that would be considered abnormal. I might have you say bear down like you're going to have a bowel movement, and it would bring the colon down a little bit further to where I could feel for masses. And then I would palpate your prostate on the laterals, bilaterally, and on the median, and I would be checking for masses, any bogginess, anything that would indicate any hardness. Anything that would indicate anything that was abnormal, and then we'd further evaluate that. After doing that, after palpating the prostate, I would pull the glove out, and I would see if there was any blood or difference in the stool. If there was, I would further evaluate that, but I would discard that, and then we'd be done. Okay, so we went over the neurologically. We went over all the cranial nerves. We went over your eyes, your nose, your ears, your mouth, your neck. We listened and went over your anterior aspect of your chest. We tested your reflexes, your pulses, peripheral vascularization. We checked posteriorly. We auscultated. We checked and percussed everything that we need to do. And then we tested your reflexes, and neurologically you're all intact, and everything looks good. So, thank you.
Thank you. Appreciate it.